major manifestations, okay, of a neurological disease. So in this we are going to talk about some of the important complaint from the patient side, like headache, like neuralgia, okay, and what is raised intracranial pressure, and what we need to know everything about that. Now, see here, let's talk about headache and facial pain. Now, headache is a very common symptom of the neurology patients. It is one of the commonest symptom actually. Sometimes headache is considered very benign type of problem, okay, and sometimes it may show some serious underlying disorders. One of the important example I like to take quickly is subarachnoid hemorrhage and brain tumor. These are very serious disorders, and they also are present with headache. And some other time, or many of the time actually, if we are stressed out, okay, if you have a bit of for example, a tension, the examination is coming up, student is studying all the time, okay, there is no rest, during that time also headache can be there. So this is not a very serious one. This headache will disappear after you take rest and some sort of analgesic. Now, headache can occur as a result of distension, traction, and dilatation of intra and extracranial arteries. So these are the different causes of headache: distension, traction, or dilatation of intra and extracranial artery. Traction or displacement of large intracranial vein. Compression, traction, or inflammation of cranial or spinal nerve. Now see that anything happen with the artery, anything happen with the vein, or anything happening with the nerve, all of them can lead to headache. Along with that, even if our muscle which are present on the head and neck area, if they are under spasm, if there is inflammation or trauma, then also there will be headache. If there is irritation in the meninges, or if there is increased intracranial pressure, there will be also headache. And sometimes the headache is there from the referred pain. Some nearby structures, okay, are having problem, and headache is there as a result of referred pain, like eye disease, ear disease, nose and paranasal sinuses disease, teeth, jaw, and temporomandibular joint problem as well. So this is called referred pain. So as a student or as a doctor, whenever somebody comes with headache, I need to think about this. Okay, there are so many different causes which can lead to headache. Now, let's talk about some of the common headache and facial pain syndrome. One is migraine. Okay, I will take a detailed class about these important types of headache later on. But right now, I will say some of the must-know points only. Now, let me list some these things, and then we'll go for the description. So, tension headache is another one. Cluster headache is the third one. These are called important type of primary headache. Raised intracranial pressure commonly gives rise to headache. There is a condition known as benign paroxysmal headache. Okay, paroxysmal means on and off type of headache, which is not very serious. That's why it's called benign. Trigeminal neuralgia causes severe shooting pain in the face region. So frankly speaking, this is not a type of headache, but this is a type of facial pain, trigeminal neuralgia. Post-herpetic neuralgia is another cause of facial pain. This is caused by, what is the cause of post-herpetic neuralgia, guys? Which virus is responsible here?
Herpes simplex virus.
Herpes simplex.
Simplex 8.
Herpes simplex.
Are you sure it's herpes simplex?
Varicella zoster virus.
This is varicella zoster virus. Absolutely. Varicella zoster virus. You are missing one thing here. This post-herpetic neuralgia, okay, is also known as shingles or herpes zoster. but the causative agent is not herpes virus. Okay, it is not called herpes virus, though it belongs to herpes virus family, but the name is varicella zoster virus. In the beginning, this patient probably had chicken pox long time ago, and the same patient will develop post-herpetic neuralgia. Okay, let me tell a little bit about these things, okay, because these are important for you. Now, migraine is a type of headache in which, okay, patient have severe headache which lasts for few hours till 3 days. Few hours till 3 days, till 72 hours the headache may last, and this is a severe type of headache. In this headache, the patient usually tends to have nausea or vomiting, and they want to take rest. They will go in a dark environment and try to sleep there. They don't like sound and they don't like light. They are phonophobic and photophobic. These are very important point about migraine. Migraine runs in the family also. Regarding the tension headache, okay, this is because of the spasm of the muscle which are lying on our scalp. So that spasm or tension in the muscle is because of stressful situation. This is a very, very common type of headache and probably considered less serious than other. But cluster headache is a very serious type. In this condition, okay, the part of the head behind the eyeball, okay, that area is the most commonly affected. It pains a lot there, and it usually have some features either on the nose or on the eye, like excessive lacrimation, okay, or some nasal discharge, some redness of the conjunctiva. Those type of features are common in cluster headache. Other things we'll discuss later. Now, when you ask about the history regarding headache, okay, you need to consider some of the important points. First of them is the onset of the headache, how it started. Okay, what was the onset of the headache? It's a sudden onset? Is it gradual onset? That's the important question. Sudden onset comes, for example, the patient was doing some other work and suddenly patient started to have headache. So usually they denote that this may be a case of intracranial hemorrhage, like subarachnoid hemorrhage, or probably stroke as well. Asks about quality, intensity, and location. Okay, quality, intensity, and location. Exactly where is the headache? Which part of the head? Is it in the frontal side? Is it on the temporal side or on the occipital side? Intensity means how bad is the headache. And quality, if the patient can describe what is the quality, what type of the headache is there. Another important question, time of and day of onset of maximal pain. Which time of the day or which time of the night the pain is maximum? We always ask this question in case of pain. Now, duration of the headache is very important question, and in case of ruptured aneurysm leading to subarachnoid hemorrhage, there is thunderclap like headache. It comes suddenly in a very severe type of headache. Patient says, I have never experienced that headache in my whole life. This is the most severe headache till today. Okay, and it is very brief also. Cluster headache is episodic and brief duration. Migraine, it is episodic but longer duration. I already told you it may last up to 72 hours, and it is relieved usually by sleep and rest along with some medicine. And brain tumor, there is early morning headache. This is highly important point in brain tumor. The patient usually complain of headache in the early morning, and there is vomiting as well. This is again because of the increased intracranial pressure. Now, asks about precipitating factors. Which precipitating factors are there, okay, for the headache? Like chewing is a precipitating factors for trigeminal neuralgic pain. temporomandibular joint disorders, TMJ, temporomandibular joint disorders, or temporal arteritis, also known as giant cell arteritis. Swallowing and tasting some food may provoke glossopharyngeal neuralgia, because glossopharyngeal nerve, or the ninth cranial nerve, is responsible for taste sensation on posterior 1/3 of the tongue. So that's why these may act as a precipitating factor. So in one sentence, this is not new for you. Any pain, okay, on our body, anywhere in the body, the questions are same. What is the onset? What is the quality? How bad is the pain? Where exactly is the pain? What time of the day and night there is maximal pain? How long is the pain? Are there any precipitating factor or relieving factor? These are the questions. Now, look at this slide. These are the features, okay, of headache. These are the important points of headache of raised intracranial pressure. It means if headache is there because of raised ICP, what are the important points there? This headache is worse in the morning time and it improves through the day. It is associated with morning vomiting. This is a highly important one, and this vomiting is usually a projectile type of vomiting. The headache is worse when the patient bends forward. There is a rise in pressure. That's why it is worse. It is worse with coughing and straining. Again, there is rise in pressure by doing this activity. It is relieved by analgesia, and it is not very severe. It is just some dull type of pain. This is headache of raised intracranial pressure. So these are the questions which we'll ask to the patient, and if most of these are present, then it is easy for us to diagnose, oh, this is probably a case of raised ICP. Now I need to find out the cause for that. Okay. Now another point here, if a patient comes with acute new onset headache, and when we take the history, the patient say, I never have this type of headache in the past. This is a new headache for me. These may be the causes. Meningitis, intracranial hemorrhage. There are different types of intracranial hemorrhage. Okay, if I want to list them, if I go from outwards to inwards, okay, I can list like extradural hemorrhage, subdural hemorrhage, subarachnoid hemorrhage, intraparenchymal hemorrhage, and intraventricular hemorrhage. See there are 5 different types of intracranial hemorrhage we can list. Let me repeat again: extradural, subdural, okay, subarachnoid, intraparenchymal, and intraventricular. These are the different types of intracranial hemorrhage. All of them can lead to headache. Brain tumor, temporal arteritis or giant cell arteritis, even glaucoma, especially the acute congestive type of glaucoma, can lead to headache. Systemic illness because of fever can lead to headache. Any febrile illness can have headache. Pseudotumor cerebri, okay, pseudotumor cerebri is a benign type of condition. Okay, this is a case of raised ICP. Okay, this is a case of raised ICP which is not caused by tumor. That's why the name pseudotumor cerebri. Actually, the problem here is raised ICP, and it may be caused by some of the drugs, like overdose of vitamin A is a common cause of pseudotumor cerebri. Cough headache. If the patient continuously cough for a longer duration, there may be headache there. After lumbar puncture, headache can be there, and after concussion of the brain, headache can be there. So these are some of the causes of acute. Okay, so let's move further. We are talking about different, important symptoms of neurological disorder, and right now we are talking about headache. There are some features which suggest headache is a severe one, or in other words, there are some, this feature shows that the underlying disease is very severe. Okay, like if there is worst headache ever in the patient's life till today, whenever we take the history, patient answer like this: doctor, I have not felt this type of headache ever in my life, it's killing me. Then we should take it very seriously. Probably this type of headache may be a feature of subarachnoid hemorrhage. Another one, first time headache and a severe headache, also taken very seriously. It may be a manifestation of serious underlying disorder. Progressive worsening over days or week is also a serious sign. Abnormal neurological exam with headache is definitely, we need to be serious regarding this. And headache which is induced by bending, lifting, or coughing, we all know this is a feature of raised ICP. So we should know the cause for raised ICP. So this is taken seriously. Early morning headache, usually a feature of brain tumor, always a serious disorder. Onset after the age of 55, it may be a case of brain tumor again. So we should take it seriously. Okay, so these are some of the important points. Please unmute yourself. Now, another part of today's discussion would be, okay, trigeminal neuralgia. So what type of disease is this? Okay, what type of disease is this? Let's talk in detail. Now, neuralgia is a nerve pain, the pain which is originated from the nerve. In this case, from the trigeminal nerve. So it's called trigeminal neuralgia. It is one of the causes of unilateral facial pain. It is commonly on one side of the face, unilateral. Now, this is very severe. Okay, it's a brief and it's an electric shock like pain, exactly like a, you know, that shooting type of pain which is going distally towards the limb in case of sciatica, a similar type of pain in the character wise. Okay, but in this case the pain occurs on the face. Okay, but the character of the pain or quality of pain is a bit similar. It mainly occurs in the region of second and third division of the trigeminal nerve. Now, how many divisions of the trigeminal nerves are there? Yes,
Three divisions.
Three division.
Ophthalmic,
Ophthalmic, maxillary,
ophthalmic, mandibular, maxillary.
very good, very good. Every students are answering very correctly. There are three divisions of trigeminal nerve: ophthalmic division, maxillary division, and mandibular division. Now, ophthalmic division is the first division, maxillary is the second one, mandibular is the third one. So usually it occurs commonly in the maxillary and mandibular division of the trigeminal nerve. That's the meaning. Now, females predominantly affected than male. We really do not know the cause for this. It usually occurs after the fourth decade of life, that is after the age of 40, and pain is brought on by chewing, brushing, or shaving. Okay, is shaving. Males are also affected here, though females are more common, but males also get the disease. So in male, shaving may precipitate the pain, and in both sexes, chewing and brushing may precipitate the pain. So the problem here is patient is afraid, you know, of shaving or even brushing because of the fear of the severe pain which may come. So this is the fear patient is having. Now etiology, okay, let's talk about it. It is maybe, we are not sure, but it may be because of the compression of trigeminal nerve by some vascular abnormality, by some tumor, or even by demyelination, demyelinating disease can be having, okay, trigeminal neuralgia. Demyelination is the loss of myelin sheath. Remember, trigeminal nerve is a part of peripheral nervous system. Okay, it's not a central nerve. Now, treatment is carbamazepine, phenytoin, or gabapentin. All of these are anti-epileptic drug. So they work for this disorder, trigeminal neuralgia. Please remember, these are the very important MCQ question you may get in exam. treatment is carbamazepine, phenytoin, or gabapentin. This is the medical management. Now, surgical management, in case of refractory cases which are not controlled by the medical management, can be treated with injection of alcohol, and we destroy the nerve there which is affected, by radiofrequency or microvascular decompression surgery. So these are only done in very difficult and refractory cases. So this is about trigeminal neuralgia. So let's move further. Now let's enter into the topic of raised intracranial pressure, a very important topic for all the students. So I hope you pay attention well here. Now raise ICP, okay, please mute yourself. Still getting a little bit of noise here, okay? Many students have not muted themselves, so please, otherwise I have to mute all of you. Now raise ICP, okay, is caused by some lesion inside the brain. That may be either by increased volume of the blood, that may be caused by increased CSF collection, or that may be caused by abnormality of the parenchymal tissue, that is brain itself. So when we analyze the causes of raised ICP, there are so many, okay? So think about a situation here, okay? I'm just I want you to understand this properly so that you'll never forget it. Now arteries will take the blood into the brain, vein will drain the blood away from the brain. So either if there is a problem in the arterial flow or disturbance in venous drainage, there will be raised intracranial pressure. That is one thing. Another one, there is CSF, okay, present inside our brain. If CSF flow is blocked, if CSF absorption is blocked, or if CSF is excessively produced, it will also lead to raised intracranial pressure. There is no space whatsoever inside our brain, okay? There is no space whatsoever inside our brain. So if some space occupying lesion develops inside the brain, that also can lead to raised intracranial pressure. So this is understanding. When we talk about the etiology, these points are very important. Now normal intracranial pressure, okay, is about 5 to 15 millimeter of mercury. 5 to 15 millimeter of mercury, and if it is more than 20 millimeter of mercury, it is definitely higher, so it is pathological. 15 to 20 is on the higher side, okay, but probably patient may not have enough signs and symptoms at this pressure. This pressure is measured at the level of foramen of Monro with a special instrument when the patient lies supine. This pressure fluctuates with the respiration. So this is about the normal intracranial pressure. Now a bit of anatomy here so that you will understand it in an easy way. So please focus. See here, this is a schematic diagram of our brain, okay, or the cranial cavity. Cranial cavity. Now this special structure which you can see, please follow the pointer here, okay. This is called tentorium cerebelli. Tentorium cerebelli. At the center of tentorium cerebelli there is a gap, okay. This is called tentorial hiatus, and through that tentorial hiatus, okay, the brain stem is passing downwards. Now this tentorium cerebelli is dividing this whole cranial cavity into two compartments. One is supratentorial compartment, another is infratentorial compartment. Let's start like this first, okay. So one big supratentorial and another one infratentorial. Now this supratentorial compartment is again divided into two halves by falx cerebri. Now this area is having falx cerebri. So this is one half, this is another. That's why it is written there are two supratentorial compartment and one infratentorial compartment. See here, it's very clear. Now let's move on. Now this picture is showing you different type of cerebral herniation which can result in raised intracranial pressure. This is not a new knowledge for you. Many students know this already. Okay, we have discussed this before. See here. Now, this is the falx cerebri. Okay, this is falx cerebri. Let me repeat a bit of once again. Here is tentorium cerebelli. This is tentorium cerebelli. This is called tentorial hiatus, and through that, especially the midbrain part of the brainstem is passing. Okay, here is foramen magnum. This is foramen magnum. Through foramen magnum, brainstem will continue as spinal cord. This is called cingulate gyrus. Cingulate gyrus. Okay, so if cingulate gyrus is herniated right below the falx cerebri, we call it cingulate herniation. This is cingulate herniation right here. Okay, number 2 is a tentorial or uncal herniation. Now see here, this is the tentorial hiatus. Okay, so through the tentorial hiatus, a tentorial notch, the uncus, which is a part of a temporal lobe of the brain, may herniate and it will give pressure to the midbrain. This is called tentorial herniation. The third one is a central herniation. The midbrain itself is herniated distally. This is central herniation. And the fourth is tonsillar herniation. Now see this. Tonsil is a part of cerebellum. So the tonsil may herniate downwards through the foramen magnum. This is tonsillar herniation. Now you may be wondering why I am bringing suddenly all these herniation part here. Because if raised ICP is excessive, then any type of this herniation may develop inside the cranial cavity, and these herniations are very serious pathology. Okay, they can have a lot of neurological dysfunction and they can kill the patient as well. Among them, the uncal herniation and tonsillar herniation are much more serious than the other. Okay, let's move further. Now see here, this is a type of herniation which is called transtentorial or uncal herniation. Now see here, there is a bilateral uncal herniation in this picture. From bilateral, see this arrow. Okay, this is a uncus of this temporal lobe of the brain. This uncus of the another temporal lobe of the brain. Both are herniated here. The bilateral, and this is unilateral. Okay, this is unilateral. Only the left side is herniated downwards. Okay, see here, and the cause is also shown here. There is a big mass. Okay, there is big mass here on that side of the brain. This big mass is causing raised ICP, which is pushing this uncus part of the temporal lobe downwards. Okay, so this is the pathological specimen. Now this is the tentorial hiatus. Again, the same area we are talking about. Okay, don't deviate your attention from here anywhere. Now which structures can be compressed because of this tentorial herniation? Which structures are compressed there? Oculomotor nerve, it is right there. Oculomotor nerve, third cranial nerve. The posterior cerebral artery is there. Okay, posterior cerebral artery, which are the terminal branches of which arteries gives rise to
Vertebral artery.
Vertebral artery.
Vertebral.
is it vertebral?
Spiral
Basilar
artery.
basilar artery.
Basilar.
Very good. It's basilar. Okay, because vertebral arteries they fuse with each other to form basilar artery. So you have to take that name. So they are the terminal branches of basilar artery, posterior cerebral. Cerebral peduncle is there. Okay, it's a part of the midbrain. It's a part of the midbrain, and there is reticular formation at the center of brainstem. So these are the structure which may be damaged or compressed by tentorial herniation. So different type of clinical features may be there. Now, what are those clinical features? Have a look here. Now, third nerve is compressed. Third cranial nerve is oculomotor nerve, and you all know what are the functions of oculomotor nerve. It supplies pupil. Okay, so what is the function of third cranial nerve in the pupil? What is the function?
Meiosis.
Meiosis. Meiosis.
Meiosis.
Good, very good. It is meiosis. Okay, it is meiosis, or it is constriction of the pupil, because third cranial nerve is a type of parasympathetic nerve, so it constricts the pupil. Now, if third cranial nerve is compressed or damaged, opposite thing will happen, that is dilatation of the pupil. Ipsilateral means same side. Okay, same side, because they do not cross now. This third cranial nerve is a lower motor neuron. Lower motor neuron never crosses. So dilation of ipsilateral pupil occurs. Never forget this. This is very important knowledge. Now, compression of the midbrain also occur in transtentorial herniation. So as a result of this, reticular formation, which is present at the center of the brainstem, is compressed, leading to impairment of consciousness. That is the function of reticular formation. Okay, the maintenance of a consciousness level. So this is important point. Please mute yourself. Hemiparesis occur because of compression of corticospinal tract. Because of compression of corticospinal tract. Okay, it is usually contralateral, but occasionally ipsilateral as well. Now, contralateral because the corticospinal fiber will cross to the opposite side when they reach medulla oblongata. We are talking of the midbrain right now. Medulla is lower than the midbrain, so till now they have not crossed. But when they reach the medulla, they'll definitely cross to the opposite side. That's why hemiparesis is usually contralateral, means on the opposite side. But listen very carefully here. Okay, this is a little bit confusing. When the pressure is excessive, it will shift the whole midbrain to the opposite side. The midbrain may be compressed by the opposite edge of the tentorium cerebelli. Now, the corticospinal fiber which are descending on that opposite side can also be damaged, leading to ipsilateral type of hemiparesis as well. Okay, so this is in the late cases. This is in the severe cases actually. Usually the paralysis is on the contralateral side, but in the severe type of compression, it may be on the ipsilateral as well as contralateral, means both sides may be paralyzed in the late stage. Now another one, hypertension and bradycardia. This is called Cushing's response or Cushing's triad. Okay, whenever I use the term triad, there has to be three things. So one thing is missing there. Which thing is missing? What is the third component?
Regular respiration.
Irregular respiratory rate.
Excellent. Very good. This is irregular respiration. Excellent. So hypertension, bradycardia, and irregular respiration, all of them can be there as a result of raised intracranial pressure. Okay, so that a part of the brain or brain stem can have respiratory center as well, so respiratory failure can also occur. Now another important point here is compression of posterior cerebral artery can lead to infarction of the occipital lobe, and occipital lobe is the center for vision. It's a visual center, so this patient may be having problem in vision. So see there, if you understand what are the structure there, the clinical features are not that very difficult to understand. Let's move on. Okay. Now, after doing this, let's talk about what are the clinical features of raised ICP overall. Okay, overall, there's so many causes of raised ICP. So, what type of clinical features will be there? Headache, we already talked about this. This headache is more severe in the early morning. Okay, and this headache will be aggravated by bending forward, coughing, or straining. It usually is associated with vomiting. and that vomiting is a projectile type of vomiting. Now, when we examine the eye, there may be papilledema. Now, let me explain this papilledema. Okay, what do you mean by that? Now, see here. Look at this picture. All of you, please pay attention. Now, there are two, pictures of fundoscopy which are shown here. This is called fundoscopy. Okay. Now, see this. This is normal. This is called optic disc. Optic disc, also known as head of the optic nerve. I'm making things easier for you. Head of the optic nerve. That means from this area, optic nerve starts. All the nerve from the retina are collected in this region, and then it will continue as an optic nerve, which will go inside the brain. Optic nerve is a sensory nerve, okay? So it will go inside the brain. Now, you can clearly see the margin of this optic disc, okay? The center is called optic cup. This is optic cup, which is a bit more brighter here, and this edge is called optic disc. And these are the blood vessels which are coming from the circumference of this optic disc towards the retina. This is called retina. So this is normal. Now let's take one scenario here. Let's say this patient is having raised intracranial pressure because of any cause. As a result of excessive pressure inside the cranial cavity, that pressure is reflected, okay, on optic nerve, and then it has come, or it has reached up to the optic nerve head. Now look at this. I cannot see any boundary of the optic disc. It is not very clear. I cannot even see the optic cup properly. And these blood vessels look fragmented. They look like broken. I cannot trace them properly. Okay, so all these features are called papilledema. Okay, papilledema. Now papilla is another term for optic nerve head. Edema of this papilla is called papilledema. See that? If you remember like this, you'll never forget. And papilledema is a very, very important feature of raised intracranial pressure. It may not be there all the time, but if pressure is high, it is definitely present. Now, this is papilledema we just talked about. Another is Cushing's response or Cushing's triad, and this is the combination of systemic hypertension, bradycardia, and irregular respiration. Okay, systemic hypertension, bradycardia, and irregular respiration. Okay. Now, impairment of consciousness level is a very common feature of raised ICP. This is because of the decompression of reticular formation. Sixth cranial nerve palsy is also a very common feature. This is called false localizing sign. So let me explain this for you. This is a very important one. Now see here, false localizing sign. Why it is called false localizing sign? Now listen here. The raised intracranial pressure can be caused by so many diseases. It may be caused by meningitis. It may be caused by encephalitis. May be caused by brain tumor. Maybe by hematoma inside the brain. Neurocysticercosis. So many. But all of these do not directly compress the sixth cranial nerve. But still this sixth cranial nerve may be damaged because of the raised intracranial pressure, okay, by so many diseases. That's why it is known as false localizing sign. Now the question is, why only the sixth cranial nerve is damaged? Why not other? Okay, other can be damaged, but sixth cranial nerve is much more commonly damaged because it has the longest intracranial course. This cranial nerve has the longest intracranial course, so it has more chance of damage. Now, which muscle is supplied by sixth cranial nerve? Which muscle?
Lateral rectus. Lateral rectus.
Excellent. This is lateral rectus. Okay, lateral rectus, and the function of lateral rectus is, what is the function?
Abduction.
Excellent. Abduction. Abduction of the eyeball. That means it moves the eyeball laterally. Now think about it. If that muscle is paralyzed, okay, so what will happen to the eyeball? What happens to the eyeball now?
Squint will occur.
Mid
Lateral eye will
reduction.
go medially.
Reduction. Mid rotation.
Eyes will go medially.
Very good. Excellent. All students are answering it correctly. It will go medially or it will have adduction. Adduction means movement of eyeball medially. That what happens. Okay. And cerebral herniations are the late feature. I have already discussed about all of them because there should be excessive rise in intracranial pressure. Then only cerebral herniation can occur. Now look at this picture here. All of you, okay, you can clearly see one eyeball is adducted, means deviated medially, okay, that is on the right side. The right eyeball is deviated medially, so lateral rectus muscle is paralyzed on the right side. That means sixth cranial nerve may be dysfunction in this case. So this type of picture is very commonly asked you in the exam. So you need to be careful. So see here, let me show you. Many students may not know it. See this eye. Look at the deviation of the eyeball here. Okay, this eyeball is adducted medially. So this is abnormal, and this is the reason for diplopia now, because this eyeball is normal. It can move according to the sight of vision. Okay, but this eyeball cannot move. It is fixed to one particular direction. So there will be diplopia. Now let's talk about infant. So in infant, what are the clinical symptoms and signs of raised ICP? Now there is an important anatomical difference between the skull of infant and older children as well as adult. That is, the fontanelle is open, especially the anterior fontanelle, and sutures are not fused in case of infant. So the signs of raised ICP are not that prominent in case of infant. Now why not prominent? That question should come in your mind, because the pressure can easily go outside from the gap of the suture. It can easily dissipate outside from the open anterior fontanelle. This is the explanation. Now see here, the head will become larger because sutures are not fused. Okay, the head will become big in size. That is called macrocephaly. Macrocephaly. In adult, head will never become big because of raised ICP. And even in children, after the fusion of suture or after the closure of fontanelle, it will not become big. It will only occur in very small babies. Another one, anterior fontanelle is tense and enlarged. Definitely, there will be separation of skull suture. There will be prominence of the skull vein. Okay, this skull vein look very shiny and prominent. This is because of the enlargement of the head and stretching of the skin on the surface of the skull. And one of the very, very important feature is called sunset sign. The sunset sign means both eyeball will be constantly pressed downward. So this baby with hydrocephalus cannot look upward. The upward gaze will be absent. This is called sunset sign, or you can also call it setting sun sign. This is a feature of hydrocephalus. These are all features of hydrocephalus in case of infant. Now I'm going to show you one picture. Just have a look here. Okay, all of you please pay attention here. Look at this head. How big is the head here? Okay, massively enlarged. And look at the skin on the scalp. It is very shiny and look stretched. And look at this vein. They are dilated and very prominent. The eyeball is covered here. Otherwise, we can see a sunset sign very clearly. Okay, so this is known as hydrocephalus. The proper term would be macrocephaly, but this is a small baby. So hydrocephalus is the most common cause of macrocephaly. So I can confidently use the term hydrocephalus here. Now, what are the investigation we like to order, okay, in case of raised ICP? Now, the method of choice would be brain CT scan. The brain CT scan will clearly show us, okay, raised ICP feature and some of the disease which are causing that as well. Skull X-ray can be taken, and if we take, there will be a separation of the suture, especially in babies or children, and the skull may show silver beaten appearance. Silver beaten appearance. Now let's see how that silver beaten appearance is seen in skull X-ray. See here. Okay, this is the separated suture. Here is the separated skull suture, and look at this very carefully. This type of appearance is called, okay, silver beaten appearance. This is a typical X-ray. Now, lumbar puncture is contraindicated in case of raised ICP. Every student know this fact. Until and unless you rule out raised ICP, do not go for lumbar puncture. And raised ICP is ruled out by some physical examination, some investigation. One of the important physical examination you have to do whenever your teacher asks you about raised ICP is fundoscopy. You have to go for fundoscopy. Okay, fundoscopy to rule out papilledema. Okay, papilledema. Okay, now papilledema has to be ruled out by fundoscopy. This is the first thing. Second one, take the vital sign. Take the vital sign. Okay, please mute yourself. Take the vital sign and look for Cushing's triad. If Cushing's triads are present, probably, okay, probably raised ICP is again there. Third one, okay, do CT scan. Do CT scan. The CT scan will confirm whether there is raised ICP or some of the disease which are causing raised ICP. And in the presence of this, please do not go for lumbar puncture. This is contraindicated because there is high chance of cerebral herniation and death of the patient. So this is contraindicated in these situations. Never forget this explanation. Now this is silver beaten appearance. Okay, in the previous picture I can see a little bit here on this edge. Okay, few of the things are shown, but in this, okay, there are very prominent silver beaten appearance. This is the one. This is only seen in chronic type of raised ICP condition. Now the time has come to know about the causes of increase or raised ICP. The one group is expanding mass inside the brain, like a cerebral tumor or brain tumor, hemorrhage, and abscess. Very easy to understand. Another group of causes would be increased cerebral blood volume, like vasodilation, which may be caused by hypercapnia or increased carbon dioxide level, that will dilate the cerebral blood vessel and leading to increased ICP. Venous outflow obstruction. Okay, now which vein drains our brain? Which is that vein?
Internal
Neural
jugular vein.
sinuses.
Internal jugular vein.
Sagittal.
Okay, now see that. So different types of answers, okay, different answers are coming, and I cannot ignore all of those answers. Actually, the main vein which drains our brain is internal jugular vein. There is no doubt about it. But internal jugular vein is the continuation of sigmoid sinus, and sigmoid sinus will start from the confluence of the sinuses, and different okay, sinuses inside the cranial cavity also drain the brain. So if you start from there, it will be excellent answer, but internal jugular vein is a very correct one as well. Venous sinus thrombosis can result in increased cerebral blood volume and then raise ICP. Another group of conditions would be increased CSF, either because of excessive production or because of impaired absorption. Now, impaired absorption may be caused by different diseases here, like meningitis. Okay, pyogenic meningitis or tubercular meningitis can cause problem in the absorption site of the CSF, leading to hydrocephalus. And excessive secretion can be caused by choroid plexus papilloma, because choroid plexus is the one which secrete CSF, and it is present inside the ventricle, mainly the lateral ventricle. Another group of causes would be cerebral edema because of these diseases like meningitis, encephalitis, hypertensive encephalopathy, head injury, as well as hydrocephalus. And one group of disorders are known as idiopathic. Okay, we do not know how this pseudotumor cerebri is caused, but this is not by brain tumor, and on top of that there are features of raised ICP. They may be caused by some drugs, overdose of vitamins and things like that. They are called pseudotumor cerebri. Okay, let's continue. We are talking about different aspects of raised ICP. Now, what are the types of cerebral edema? Remember, cerebral edema is one of the common cause of raised ICP, and cerebral edema can be caused by so many different disorders of the central nervous system. Now, there are three types of cerebral edema: vasogenic edema, cytotoxic edema, and hydrocephalic edema. Now, what is the meaning of them? Okay, vasogenic, cytotoxic, and hydrocephalus. Now, the pathogenesis of vasogenic edema would be increased capillary permeability. That means the capillary wall become leaky. So a lot of fluid comes out from the capillary and collected inside the white matter of the brain especially. So the edema fluid would be plasma filtrate, and in this case these are the causes or syndrome: tumor, abscess, cerebral infarction, hemorrhage inside the brain, lead encephalopathy. This is the damage of the brain by lead. Lead is a type of heavy metal. Okay, ischemia, and even meningitis. All of these can lead to vasogenic type of cerebral edema. Another type is cytotoxic. This is because of cellular swelling itself, and this can occur in both gray and white matter. The type of edematous fluid here is excessive intracellular water as well as sodium. So you can understand the cytotoxic edema may be seen mainly in electrolyte disturbances. Okay, and if we give a lot of IV fluid to the patient, this can happen, along with some other feature like some other disorders, I should say, like hypoxia. Okay, decreased osmolality that can happen if we over dilute our plasma, ischemia, meningitis, and even in Rey syndrome. Rey syndrome is caused by giving aspirin in case of viral infection, mainly in children. Now, the third type of cerebral edema is a hydrocephalic cerebral edema. This is because of increased intraventricular fluid, which is definitely collects inside the ventricle, but it may leak in the periventricular tissue surrounding the ventricle. Okay, so it is seen in hydrocephalus, and there are two types of hydrocephalus: communicating and non-communicating one. So in both conditions, hydrocephalic cerebral edema can be seen. But remember, it is not a generalized type of cerebral edema. It is seen mainly in the area which are surrounding the ventricle. Let's move on. Now, all of you, please focus on this, okay, picture. Now, see here. This is a CT scan of the brain, and there is a mass here. This may be a hemorrhage or a mass. Okay, we cannot confirm it by this picture, but look at this brain in other parts. See here, this is hypodense area, which I can clearly see. generalized hypodense area. So this is called cerebral edema. Very clear-cut picture. Now, all of you, please see here carefully. Okay. See here now. Okay. So let me unmute you again because of a lot of disturbances. I've muted all of you. Now see here. So look at this CT scan of brain once again. So which type of hydrocephalus is this? Okay, just see, look at the picture and tell me.
It looks communicating hydrocephalus. Communicating one.
Okay, so you are talking about
Because all the ventricles are dilated, so it looks communicating one.
good.
Lateral ventricles are dilated. That's why.
Okay, good. Now see here. That's a correct answer. Okay, that's a correct answer. But let me explain for all other students. Now see here. Let me highlight and explain. Now see here, these ventricles, all of the ventricles are dilated here. Now see, look here very carefully. Look at the pointer, okay? This, okay, here and these frontal two are the parts of lateral ventricle. These are the different horns of lateral ventricle. This is the fourth ventricle, which is posterior, fourth ventricle, and this middle one is the third ventricle. All of these ventricles are dilated. That means most probably the pathology or the disease is located at the absorption site of the CSF. Okay, that means the subarachnoid space is nicely connected or communicated with the ventricular system. There is no obstruction in between them. CSF is nicely flowing from the ventricle into the subarachnoid space. So this is called communicating hydrocephalus. Communicating hydrocephalus, and the most common cause for this is obstruction, disease at the absorption site of the CSF. So this is the way, okay, you need to understand. Now look at this, another picture, okay, see here. Now look at this big mass here, okay, look at this big mass. This is definitely tumor inside the brain, okay, tumor inside the brain, and there is one tumor which behaves like this, and the name of that is glioblastoma multiforme. Glioblastoma multiforme, it's a type of malignant astrocytoma, and the prognosis of this type of tumor is very, very poor. Now we have come to the end of this topic. Now the final part is treatment. So how we treat a case of raised ICP. Now see here, raised ICP is monitored with the ventricular catheter or surface pressure electrode, and the treatment is instituted when the mean intracranial pressure exceeds 30 millimeter of mercury. Okay, between 5 to 15 is considered normal. More than 20, you start to have clinical features of raised ICP, but when the pressure exceeds more than 30, you definitely need treatment. So goals of treatment would be some of the general measures by which we reduce the raised ICP, and there are certain definitive treatment. That means whatever disease is causing the raised ICP, we must treat that disease or remove that cause. So this is the goal or the objectives. Now, what are the general measures by which we reduce raised ICP? Now, the position of the patient in this regard is head elevation up to 30 degree in neutral position. The patient should lie supine and the elevation of the head, okay, up to 30 degree. This is the best position to decrease the effect of raised ICP. We have to give some diuretics and the important two diuretics are mannitol and furosemide. The mannitol is osmotic diuretic or osmotically active diuretic, which is very important drug in this condition. That is a very important drug called mannitol. So we have to give this mannitol either as a single dose or in divided dose. Another important drug is furosemide, which is a loop diuretic. Okay, this is also important one here. Another thing we can go for is controlled hyperventilation. Now this controlled hyperventilation is done by mechanical ventilator. So we attach the patient in with mechanical ventilator, and we have to decrease the carbon dioxide to 30 to 35 millimeter of mercury. The normal level of carbon dioxide in our blood is about 40 millimeter of mercury. So we need to decrease this value to 30 to 35 millimeter of mercury. Okay, this will also help because excessive carbon dioxide concentration in the blood is causing vasodilation inside the cranial cavity. That vasodilation is further increasing intracranial pressure. So by doing hyperventilation, we are washing out that excessive carbon dioxide. This is the mechanism. Sedation and muscle relaxation can be given. CSF can be removed. Okay, and this removal of CSF is mainly done in case of pseudotumor cerebri. The treatment in pseudotumor cerebri itself is removal of CSF. Now, one specific treatment we can do in these conditions, that is shunt. This is called intracranial shunt, and one of the important type of intracranial shunt is called ventriculoperitoneal shunt or VP shunt. Okay, VP shunt. So let's talk a little bit about that. Now, this shunt is a device, okay, which is used to reduce intracranial pressure by draining of CSF from a dilated ventricular system somewhere else. So it will drain CSF from the ventricle either into the peritoneal cavity, okay, or either into the atria. So accordingly, the name has been given, ventriculoperitoneal shunt, from the ventricle to the peritoneal cavity. Now, there are different components of the shunt. One is ventricular catheter. Definitely, it is inserted into the lateral ventricle. Okay. Then another is subcutaneous reservoir with one-way valve. Now, this reservoir is very important part because sometimes there is obstruction in the flow of the CSF. If that happens, then we can keep on massaging or keep on applying a little bit of pressure in that reservoir, and it may open again. Another component is a distal catheter, which is reaching the site of drainage. In case of ventriculoperitoneal shunt, it is inside the peritoneal cavity. In case of ventriculoatrial shunt, it is inside the right atrium. But I already told you, VP shunt is far more commonly done than ventriculoatrial shunt. Now, alternatively, there is one more shunt which can be kept. It is called lumboperitoneal shunt. Now, this lumboperitoneal shunt means there is a dilated area surrounding the spinal cord, which is called lumbar theca. And in case of raised ICP, also there is a lot of CSF collection there. So one end is kept in the lumbar theca and another is in the peritoneal cavity, but this is not very commonly done. Okay, so these are some of the components of the shunt. In case of aqueductal stenosis, this is called cerebral aqueduct of Sylvius, and this aqueduct stenosis is one of the common cause of hydrocephalus, which is known as non-communicating hydrocephalus now, or obstructive hydrocephalus. It may be treated by a shunt from the lateral ventricle into the cisterna magna. This is another dilated area in the ventricular system. So these are a different type of concept. Now look at this picture here. Okay, look at this picture very carefully. This is a picture of, let me show you and explain. See here, this is a CT scan which is showing dilated ventricle. So this is hydrocephalus. Okay, this is the small shadow you can see clearly here. Okay, this is the tip of the shunt. This is the tip of the shunt, and this is a schematic diagram of that baby who is having big ventricle, that is hydrocephalus, and this is the tip of the shunt which is kept inside the ventricle. This dilated area is called reservoir, and this is the subcutaneous component of the shunt, and the distal part of the shunt is kept in the peritoneal cavity. So this is VP shunt. Okay, this is another CT scan which is showing the tip of the catheter there in the ventricle. And look now, it has completely drained most of the CSF already, so no more dilated ventricle is seen here. Okay, now what are the complications of this shunt? What can happen? The shunt may be infected because this shunt is a artificial thing which we are keeping, isn't it? So infection can occur during the surgery or even after some time. Blockage of the shunt can happen, and it will again cause raised intracranial pressure. Chronic subdural hematoma because of the pressure difference. If there is too much drainage of the CSF, then pressure may be suddenly low inside the cranial cavity, which may precipitate subdural hematoma. Low pressure state can lead to headache. Platelet fibrin emboli or thrombus can form there. Shunt nephritis can occur. This is one of the important complications. Kidney damage may happen, and even sclerosing peritonitis can occur because of BP shunt. But even after all of these complications, the benefit which is there for the patient is far, far more than these complications. So this is one of the very popular or common type of treatment in case of hydrocephalus.